Now that we're in the abdomen and pelvis, don't forget your ABCs. A quick abdominal and pelvic exam will often be a part of your primary survey. So remember, you're not leaving behind the basics, you're just adding to what you've already covered. First and foremost, let me tell you, if you don't know your anatomy here, you're going to be in a world of hurt. In ATLS, it's assumed that you already have a working knowledge of the anatomy. So you need to have a working knowledge of the abdomen and pelvis to get the most out of what's covered in this chapter. Pull out your favorite anatomy book and start reviewing. Clearly, when you know the mechanism of injury, your level of suspicion is raised for specific injuries. And although you may see physical clues like a seatbelt sign, it's still necessary for you to get this information from EMS when they bring the patient in, because the patient may not be able to tell you. If the patient is able to talk, then the mechanism of injury is an important part of the history. Mechanism of injury is typically divided into two areas, blunt and penetrating, but there can be significant overlap. For example, a high-velocity shotgun blast or an explosion typically causes blunt and penetrating injuries. Motor vehicle crashes can involve projectiles causing penetrating injuries as well. So be on the lookout for potential overlap when you're nailing down the mechanism of injury. In the primary survey, your immediate killers are found and addressed. If you suspect an abdominal source of shock, then by all means do a FAST or DPL sooner rather than later. As more clinicians are becoming comfortable with ultrasound, FAST is becoming more common. If you're not comfortable with doing a FAST, then take a look at some of the YouTube videos in the skills section that I suggest before you get to the course. Hopefully, this will help you with recognizing negative and abnormal images and the placement of the probe. You'll get to practice a little at the course, but it won't be enough to make you comfortable without additional review and practice. This goes for DPL as well. Remember, with your DPL, gross blood greater than 10 milliliters, GI contents, vegetable fibers, or bile all mandate laparotomy for the patient in shock. Also, you need to remember that pelvic stability should only be manually checked one time by one person in a stable patient. You should not be checking pelvic stability in a patient in shock. This maneuver can aggravate bleeding. As you know, the secondary survey is a complete head-to-toe evaluation, including a complete history and physical exam. And you'll do this once the patient has been stabilized. The ample history should be obtained. The patient, EMS, police, passengers, witnesses, whoever can all give you useful information. Don't overlook anyone. Be as thorough and detailed as you can when getting information on mechanism of injury, like speed of the car, height of a fall, area of impact on the car, restraints, airbags, intrusion, type of weapon, distance from assailant, number of wounds, etc., etc. Leave nothing out. The physical exam in the secondary survey should be meticulous, starting from head to toe, scalp, ears, eyes, nose, mouth, all the way to the bottom of the foot. Don't forget to recheck areas you've already looked at in the primary survey for missed injuries or changes in status of an injury you've already identified. The abdominal exam may be benign or equivocal initially, but serial exams can be very helpful to you. You may have already placed a G-tube during the primary survey, but if not, you can consider doing it now. But remember, no NG tube for patients with facial fractures. By now, you probably have done your FAST or DPL on your unstable patient, but if the patient is stable, you can get a CT of the abdomen and pelvis based on mechanism of injury. Most trauma patients going to CT get a head, C-spine, and chest CT as well. Your hypotensive or unstable patient should not be sent to CT. Why? because the last thing you want is your patient to crash in the scanner when there's no one in the room with him. And one more point in this secondary survey section: esophagram versus endoscopy. One of these may be indicated if you suspect esophageal injury. Go ahead and get your surgeon involved at this point. The pelvic exam includes a check of pelvic stability, perineal, GU, gyne, rectal, and gluteal exams. You should inspect every crevice. Blood at the urethral meatus, perineal hematoma, a high-riding prostate means no Foley without first doing a retrograde urethrogram. If you see a urethral injury, you may need a suprapubic catheter. I know you're focused on the pelvic exam, but if they've not already been done, now's the time to get your chest x-ray, pelvic x-ray, CT scan, and other imaging. And if the patient needs to be transferred, don't wait for the imaging. Go ahead and transfer the patient. So here's the question: when does the patient need to go for laparotomy? Most of the time, that's usually a judgment call by the surgeon. But there are some guidelines listed in the book when it's fairly obvious the patient needs to go to the OR. Take a look at pages 133 and 134. When you have patients who have a concerning mechanism of injury, but no signs or symptoms that warrant immediate surgery, then you should observe these patients with serial abdominal exams and possibly a double or triple contrast CT. On serial exams, you need to look for things like increased abdominal pain, increased abdominal tenderness, persistent emesis, inability to tolerate a diet, unexplained hypotension, increasing leukocytes, increased amylase, partial small bowel obstruction, or abdominal sepsis. As I mentioned at the beginning of this chapter, your suspicion for specific injuries is raised by the mechanism of injury. An unrestrained driver in a front impact collision or the classical bicycle handlebar injury should raise your suspicion for duodenal rupture. However, mechanism of injury could be a restrained driver with an incorrectly placed seatbelt. Don't forget to look for a chance fracture of the low thoracic or lumbar spine in these patients. Duodenal injuries and pancreatic injuries are graded on a scale of 1 to 5. You don't need to know the classification for the test, but you do need to remember to be vigilant for worsening in patients that are observed. As the duodenum and pancreas are adjacent, an injury to one should raise your suspicion of an injury to the other. A direct blow to the epigastric area also raises suspicion for injury. Checking serial amylase and lipase will be more helpful than just getting a single elevated amylase. For pancreatic and duodenal injuries, even though we have the benefit of high-resolution CT, these injuries can still be missed. Be mindful of this, as you may need to repeat the scan later to be sure. And also keep in mind that ERCP can be diagnostic and therapeutic for pancreatic duct injury. Genitourinary injuries are rarely life-threatening, but a shattered kidney, an avulsion of the renal pedicle from deceleration, a major renal vascular laceration, or renal artery dissection can all threaten life or kidney. Usually, genitourinary injuries are evaluated and treated after the potentially life-threatening injuries have been dealt with. Genitourinary injury red flags that you should be on the lookout for include blunt trauma to the back or flank with visible bruising, penetrating trauma to the flank, hematuria, pelvic fracture, scrotal or perineal hematoma, or blood at the urethral meatus. And make sure you don't rely solely on the rectal exam. Why? Because getting an accurate rectal exam on an obese patient on a backboard, yeah, that can be challenging. But know that you still have to do the rectal exam. And don't forget the vaginal exam, assessing for lacerations from pelvic fracture. Keep in mind that in patients with gross hematuria, you will want to do a retrograde cystography. But in patients with pelvic fracture, with concern for significant vascular injury, retrograde cystography should be deferred until angioplasty has been done because it may obscure the angiogram. In patients with a positive seatbelt sign, be suspicious for other hollow viscous injuries also. The jejunum and ileum, colon and rectum are more frequently injured than the duodenum. These can be difficult to diagnose, especially if there's no perforation, but a significant devascularization injury could still be present. You should know the CT findings that suggest GI injury include pneumoperitoneum, mesenteric air, free retroperitoneal air, discontinuity of part of the wall of the GI tract, extraluminal enteric contrast, free fluid without solid organ injury, extravascular IV contrast, bowel wall thickening or edema, mesenteric hematoma. If your first scan is not diagnostic and your suspicion is raised on serial exam, then go ahead and explore and/or rescan depending on your patient's condition. Solid organ injuries are more frequent, but can often be managed non-operatively if the patient is hemodynamically normal. These patients should typically be observed in the ICU. You should have identified and addressed an unstable pelvic fracture in the primary survey. Prior to moving the patient to angio or the OR, you should place a pelvic binder, a sheet, an external fixator, or a C-clamp to stabilize the pelvis. Mortality is high in these injuries. Pelvic fracture can include ring disruptions, avulsion injuries, sacral fracture, and acetabular fracture. However, you need to be familiar with the classification of ring disruptions mentioned in the book, which are lateral compression, AP compression, and vertical shear or combined injury. Any of these injury patterns can lead to an open book fracture. If the anterior ring widens more than 2.5 centimeters, this significantly increases the likelihood of injury to the posterior pelvis. Many hospitals have commercial pelvic binders, but hey, don't forget that the old-fashioned sheet works. Also, don't forget Chapter 3. Volume and resuscitation go hand in hand with stopping the bleeding. If you don't have ortho or interventional radiology available at your facility, then for the unstable pelvic fracture patient, transferring the patient early is ideal. There's no need to delay. And finally, in the hemodynamically normal patient, CT is the imaging of choice.